Good evening and welcome. Myself, Dr. Sunita Ingre, welcome you all on all the dignitaries who are present on the Zoom platform, as well as the viewers who are watching us on the YouTube Live to this unique academic session of Maha IIP Case Challenge. I am happy to note that office bearers of the Maharashtra State IIP are here today. Dr. Hemant Gangolia, sir, who is the president, Dr. Amol Pawar, secretary, Dr. Jay Bhandarkar, who is the convener, and also Dr. Mahesh Mohite sir, who is actually the brain behind this concept. Our expert today, respected Dr. G.V. Basavaraja sir, and of course the moderators today, Dr. Sunil Vaidya sir, Dr. Shiv Mundada, and the teams who are in the hot seat today, the team Dhure and team Jalgaon, who are here. I will request Dr. Hemant Gangolia sir to give his opening remarks. Over to you, sir.
Hello. Hello, I'm audible.
Yes, sir. Yes.
Okay. Thank you, madam. Life is full of challenges as our profession. This is the Maha challenge going to be run by
your voice is
the
breaking,
great
sir.
Moderators. Okay. Voice is breaking, so I'll stop my video and just I will try. Otherwise, then you can proceed.
Video बंद कर
So now it's audible.
माइक आता आवाज येतोय. हेमंत आता आवाज येतोय.
आता येते आवाज.
हां दे.
So life is the 7th episode of a Maha Case Challenge, where we are going to see the cases thrown by our great moderators, Dr. Sunil sir, Dr. Sir, at two intelligent teams from Jalgaon and expert channelization by our mitochondria guru, Basavaraja sir, where we learned the thought process in the case. And heart thanks to the coordinators who have watched these all 7 episodes across the
lost. I think we have lost him again. Okay. I think his connection is poor, so we lost him. Now I will request Dr. Amol Pawar to say a few words. Can give best
Good evening, all. Good evening, all teams and all the dignitaries on dais. This is a nice initiative by Dr. Mahesh Mohite sir, and equally helped by Dr. Shilpa and Dr. Sunita Ingre ma'am. And various cases are discussed, and various cases are actually diagnosis is made from various these things, point inputs given by the moderators. And this is nice initiative to connect all the various branches across Maharashtra IIP. I welcome G.V. Basavaraja sir for this episode also. And thank you Sunita ma'am. Please continue.
Thank you so much, Dr. Amol. Now I'll request Dr. Mahesh Mohite sir to please give his comments.
Thank you, Sunita. First of all, welcome Dr. my dear friend Dr. Basavaraj for accepting this invite. And believe me, it's very difficult to find a faculty who is an excellent generalist and plus having his own super specialty. Today, it's very easy to get a good super specialty in any. Ask me 5 cardiologists, I'll quickly tell you. Ask me 5 neurologists, I can quickly tell you. Ask me 5 good, excellent generalists, extremely difficult. And that's how we have chosen you. So you can realize what we mean that, okay? So with that, just a briefing of this whole concept of this is basically on the conference dais, we get sort of panels which are prefabricated. You very well know that, Basavaraj, because you have been a kind of academic setter for many of the national conferences. So generally, you are a panelist and you are a moderator and the panelist ask you, कौन सा question पूछेगा? बाद में 2 दिन के बाद इसको आंसर क्या है? Whole thing is so boring. So this is what is come out of. We wanted hardcore academics out of this, and we are giving absolute raw cases at this point of time. Maharashtra don't know which cases, who are presenting and who are receiving. And at this point, these 2 teams and the moderators, they themselves don't know to whom they are presenting and who is going to get that. So everything is kept absolute blank. Even I don't know this time Probably Sunita and Shilpa know that. So they'll be declared who's going to present to whom. So that's kind of a thing. And idea is basically to crack the case from the history, from the clinical examination, and then maybe from the investigation if required. And you will not believe, Dr. Basavaraj, in last 6 sessions, I would say barring one case, remaining all 11 cases were cracked by our teams, all receiving teams, just on the history or on the clinical examination. That's a caliber we are having sitting in the district place. So idea is to have a completely academic quality program, and that's where you are. And your role at the end of the case, you will be giving your expert comments on that particular case, the approach and all. And that's how the session will go. Thank you very much again for accepting it. And thank you, Maharashtra IIP, for giving us this opportunity to host this program. It's over to Dr. Sunita.
Thank you so much, sir. Now it is my very pleasant duty to introduce our expert today, respected Dr. G.V. Basavaraja, sir. Actually, sir needs no introduction. Sir is a very well-known academician and
He's from Maharashtra.
teacher.
He's from Maharashtra only.
Achha, that's nice to know. Sir is Professor of Pediatrics and PICU in charge at Indira Gandhi Institute of Child Health, Bangalore. And sir has over 20 years of teaching experience. He is a course coordinator for fellowship in pediatric intensive care. Sir has held many important official posts during his career. And sir has been the founder secretary of IAP, Infectious Disease Chapter Karnataka 2011. He's been the chairperson of IAP Intensive Care Chapter in the year 2020. He's been the honorary secretary general in the year 2021, convener of Scientific Committee Pedicon 2017 and 2018. Sir has more than 80 publications in indexed national as well as international journals. Sir has been awarded the Fellow of IAP Award in 2017, and he has also been honored with Dr. B.C. Roy Award by IMA Karnataka in the year 2020. Sir, I would request you to give best wishes to the team and say a few words. Over to you, sir. Dr. Basavaraja, sir.
Thank you so much, Dr. Sunita Ingle, madam, for your nice word. Coming to Maharashtra is always in a homecoming, what Dr. Maheshji said. So thank you, Maheshji, for your love and affection and the words you have used. And respected President of Maha IAP, Dr. Hemant Gangolia, sir, and a dynamic secretary who has been galvanized in a Maharashtra Maha IAP to the greater heights, and young and energetic Amul Pawarji. Of course, this is a concept which has been well concepted. Anything Dr. Mahesh does is always does within a totally core academics. So this is one of the what I could understand with this is one of the thought-provoking exercise for a clinician. How we need to be a clinician. These are the things which has been taught over a years, more than almost 4 to 5 decades by none other than our teachers of teacher and the great our YK Amdekar sir, Rajesh Chokani sir, Mahesh ji himself. And Thursday teaching is one of the things which has been well perceived. It is something which is more than that. And Mahesh is taken a clue from there with the help of our Sunita madam and Shilpa. Really appreciate. This is not an easy thing to coordinate and do all these things. And today's team by our Dole and Jalgaon, Dr. Shivprasad sir and Parikshit sir and all the seniors. And wish you all the best for the team and the great support by all the office bearer and the academic stalwart like Sushma madam and many more who has been joined here. So without wasting much time, so wish you all the best for the team. I'm looking forward to enjoy the academic feast and session which is going to be there for next 1.5 hours.
Thank you, sir, for your words. Very nice to hear them. Now I will hand over the proceeding to Shilpa. Over to you, Shilpa. Let's go ahead.
I hope I am audible.
Yes, you are.
Good evening to all the seniors and friends. Thank you for joining with us today.
Shilpa, a little louder, please.
Okay. This is our 7th session of Maha IAP case challenges, and today we have our 2 very eagerly waiting team members and moderators with their interesting cases. So our moderators for today are Dr. Sunil Vaidya sir. Sir is a professor and head of the Department of Pediatrics, Ashwini Rural Hospital, Sholapur. He is a teacher for UG PG and has published many research papers and chapters in textbooks of pediatrics to its name. Our second moderator for today is Dr. Shiv Prasad Mundara sir. Sir is a professor in Government Medical College, Latur. He is a trainer of NALS, PALS and is an eminent faculty and also has 25 publications in index journals. We have a good team of moderators. Our teams for today are from Dhule and Jalgaon. From Jalgaon, we have with us Dr. Surendra Patil sir, Dr. Rahul Patil sir, Dr. Avinash Bhosle sir. And from Dhule team, we have with us Dr. Yogesh Salonke sir, Dr. Parikshit Diore sir, and Dr. Mahesh Arirao sir. So before starting, let me quickly go through the few rules. Each moderator will get only 25 minutes for presentation and discussion. The next 5 minutes will be kept for expert comments. Kindly stick to the time mentioned. No posting any comments on the chat box. If there is any question from the audience, we will try to answer it at the end of the session. So without wasting our time, I will request Dr. Sunil Vaidya sir to please share his screen and start his presentation. And he will be presenting to team Dhule, which is Dr. Yogesh Salonke sir, Parikshit Diore sir, and Mahesh Arirao sir. Dr. Sunil sir, kindly unmute yourself.
Am I audible?
Yes.
Yes, sir. Yes.
Yes, sir. Good evening. Today's respected guest, Dr. Basavaraj, President Maha, Dr. Gangulia, Dr. Amol Power, Secretary, Dr. Mahesh Mohite, and key participants are all yours. Good evening to all.
Good evening, sir.
Good evening.
I am presenting a case. It is because we wanted a Hatke case. That is why I selected a case pre-COVID era from a clinical meeting. This was a 2 months old female child presented to hospital by her parents with chief complaints, fever for 15 days, excessive irritability, not accepting feeds for 5 to 6 days. And these symptoms got worse and she was brought to our tertiary care center. Now, this fever was intermittent, sometimes a high-grade fever, but was persistent in spite of symptomatic treatment. She was given antibiotic 2 times by the previous people. There was no history of cough, cold, no history of loose motions, vomiting, no history of skin infections, ear discharge, or focus of infection. There was no history of jaundice. There was no history of seizures. In past history, as such, no major illness was informed. No history of maternal illness, gestational diabetes mellitus, pregnancy-induced hypertension. No history of fever with rash during pregnancy. The birth history was normal vaginal delivery, second child. First child is 3 years, normal child. This child cried well after birth. No events were reported. In family history, the second degree consanguineous marriage, first child, 3 years normal growth. No history of tuberculosis in the family. Milestones, the child has achieved a social smile. Now, after chief complaints, do you want to comment on some where we are heading? Where we are heading?
Going by the symptoms of fever, irritability, and refusal to feed, we probably feel that this is pointing towards some CNS infection.
Yeah.
Primarily, what we feel from the symptoms is like it is heading towards some CNS infection.
So initially, it looks like a a refractory infection
Yes, but
of some kind. Okay.
yes, sir. Going by
Now
pallor,
proceed.
Acha, that will cover in physical exams. Okay.
Will you like to ask any more history?
No, sir. No, sir.
Consanguinity is there, second degree consanguinity.
No, sir. We will move to physical examination.
Yeah. Okay. The child was well nourished, as you see, conscious, alert. There was no dysmorphism or any syndromic features, facies or something, polydactyly or something like that. Anterior fontanelle was normal, by 2 centimeters, not bulging. Because with the weight of 5.1 kgs and head circumference 36 centimeters, temperature was 100 degrees at that time. The examination pulse was tachycardia 148 per minute, respiratory rate was higher, BP was normal. And there was pallor, quite a pallor, and bruising was seen at the venous sites. There was no edema, no icterus, no cyanosis, no lymphadenopathy. Now, proceeding to systemic examination, the central nervous system, the higher functions, told deep tendon reflexes, all were normal. The respiratory system, there was bilateral air, normal air entry, no added sounds. The cardiovascular system, heart sounds were normal, no gallop, no murmur. Per abdomen, the liver was enlarged 5 centimeters per and non-tender. Spleen was enlarged 5 centimeters firm and non-tender. Now this is the child. As you can see, the quite is not a good nourished child, and you can see the hepatosplenomegaly, and you can see bruising at elbows and pivotal fossa. Any clinical conclusion?
Sir, in physical examination, we had pallor and bruising. It suggests that there is drop in hemoglobin, as well as there may be drop in platelets as well. With both liver and spleen involved, it points towards some hematological abnormality, maybe some sort of malignancy. We have seen cases of ALL in this age as well.
Absolutely.
But I think we should keep in mind that you mentioned this is a second degree consanguineous marriage as well. So we need to keep in mind as well. So we may be heading to some storage disorder maybe.
Age is 2 months, so more likely some congenital etiology. But fever, which is striking, that fever which is not resolving since 15 days, associated with organomegaly and pallor. So let us see the peripheral smear of this patient.
I will proceed to
Investigations.
Regular investigations were done.
30,000.
The hemoglobin was 5.4%. Gram percent, hematocrit 16. MCV 66, the retic count was 3.8%. WBC count was 6,800, neutrophils 26, lymphocyte 64. Eosinophils 6%, platelets 30,000 per deciliter. Now the peripheral smear showed some teardrop cells and target cells and isopylocytosis. CRP was 29 mg/%. Urine normal, no pus cells. Liver function test, SGPT 344, SGOT 430, slightly elevation of enzymes. Albumin was 3.2 gram%, INR 1.4. X-ray test was normal. Fundus was normal. Fundoscopy was done for a special intention. It was normal. And USG of abdomen showed splenomegaly and hepatomegaly. Kidneys were normal. There was no mass or some malignancy was seen.
So serum bilirubin,
BSL किती
serum bilirubin or any other thing.
BSL किती
Hello, sir. Hello.
Will you like any more investigations?
sugar. Sir, what was the blood sugar?
BSL was normal. It was
Normal. And
BSL
bilirubin,
was
serum,
normal.
serum bilirubin.
We took morning samples also. They were also normal. I have not mentioned, but yes, blood sugar was normal.
Serum bilirubin and other liver functions, proteins, serum proteins.
Serum proteins 3.2. I have told the albumin was 3.2.
Bilirubin was not mentioned.
Sir, hello.
Ah.
Our initial impression of anemia and thrombocytopenia was confirmed on investigations. Teardrop cells and target cells on bone marrow on the peripheral smear shows some evidence of hemolysis going on. The transaminases which are raised could be just because of mild hepatomegaly. So they don't seem to be significant.
Yes, CRP is very high. CRP is 29.
Yes, sir.
Can be part of that process
Yes.
also, septic process.
Sir,
also.
we need to know whether we have gone with the bone marrow examination and whether HB electrophoresis was sent for this child.
I don't know what is happening.
Sir, this looks more of a well-grown child who is suffering, who is developmentally normal, birth history normal, presented 15 days back at the age of 1.5 months. That irritability, decreased feeding could be related with the severe anemia the child is having. But the severe anemia in the context of hepatosplenomegaly with thrombocytopenia. So some bone marrow evaluation, whether we are dealing with malignancy, because WBC count is showing some neutropenia. Otherwise, it is not showing any band cells or any other things that we are getting.
Sir, your presentation, can you go down?
Yeah,
to
it is not.
Can someone help?
Bone marrow picture.
Now you can share, sir. Now you can share.
Just a minute.
Start sharing again.
Sir,
Vaidya sir, start sharing again. It will come.
No, the presentation is moving automatically.
No, exactly. So you start sharing again. Perhaps it will work now.
Sir, go to first slide and then go forward. Slideshow.
It is coming directly.
go to slideshow, sir.
Sir, you just click on the slideshow first.
Huh?
Slideshow.
Click on the slideshow button first.
Okay.
Okay.
On right.
Now click from beginning. Okay, sir. It will work. Sir, you are moving. You must be moving your mouse.
No, sir.
Sir, go to from beginning, please.
सुनीता मॅडम बॅकअपला घेतलंय का हे? नाही.
Time.
बॅकअपला हे पीपीटी घेतलंय का? म्हणजे
Nice. No.
Sir, click on any slide, sir. Click on any slide. Just click on the
Double-
left side. So I'm asking for the request. Just accept it. Sir, I'm operating your presentation. Just wait, sir. Wait there, sir. I'm operating your presentation. Just wait. Wait there, sir. Can you just share me?
Slideshow, sir.
Should I stop sharing?
Stop the sharing once and try again, sir.
Yeah, sir.
Sir, if you are unable to share, we can go, you just present, we will write down the things and we can continue with the case.
So Vaidya, can you see your presentation?
Yes, sir.
Yeah.
Yes.
Start doing it.
Sunil sir.
Dr. Vaidya, this is the presentation slide you wanted. Dr. Vaidya, you are there? Hello?
Vaidya, unmute. Vaidya, sir, unmute.
Dr. Vaidya, sir, you are there?
Yes.
So which slide you want? This is the investigation slide, right?
Yeah, it's right.
This is one which you had sent me a raw presentation. I'll go through that. Perhaps that should also will suffice, right?
Right. Okay.
So this was his initial presentation and most of the parameters you know. You want to take it up?
Yes, sir. We are written.
We have written those things.
We are Plavan.
Huh.
We have written.
Yes, sir.
This also you have seen. This was
Yes, sir.
Yes, sir. Yes.
Hospital course now we are about to begin. Yes, this is not seen.
Sir, we'll start from this one, hospital course.
Yeah.
Go
This
has come to the end now.
The one which you had sent is this only.
Sir, you try again sharing. Again, you start sharing. Close the presentation.
Yeah,
Dr. Sunil sir,
sharing.
you close the presentation. Start sharing again.
Okay.
And start from the first slide. Just go to slideshow. From beginning, ला type करा तुम्ही.
No, I'm typing. It is enter.
From beginning ला type करा तुम्ही cursor तुमचा हलती ते हे करता ते move होते. From beginning ला तुम्ही type करा. From beginning वर पहिला column.
Yes,
From
yes,
beginning वरती हाँ. त्याला double type करा. करा double हाँ. आता येईल.
नाही.
तुम्ही तिथे कर्सर हलवा. एकदा क्लिक झालं ना बाजूला कर्सर करा मग माउस वरती नका ठेवू. मग तुम्ही एक ह्यानी क्लिक करा. लॅपटॉपच्या कीबोर्डनी परत फ्रॉम बिगिनिंग जावा तुम्ही.
सर काहीतरी प्रॉब्लेम आहे.
नाही ते काय कर्सर त्यांच्या तिथे राहून जातो त्याच्यावर ते पुढे सरकतं ते. फ्रॉम बिगिनिंग परत करा एकदा करा.
पल्लवी मॅडम तुम्हाला बॅकअपला घेता येईल का?
हो, मी माझा आयडी लिहिते सर. मी तिकडे घेते प्रेझेंटेशन.
नाही त्याला वेळ लागणार. तुम्ही रिक्वेस्ट तुम्ही फ्रॉम डबल टाईप करा आणि कर्सर तिथून हलवा मग कीबोर्डने ऑपरेट करा. माउसने नका करू.
सर त्यांचा ना माऊस बहुतेक स्टक झालाय.
हँग झालाय माउस झालाय तुमचा.
Mouse पण change केलाय मी. I have changed the mouse also, but some
ना
Dr.
don't
Vaidya-
use
Vaidya
mouse. तुम्ही माउस काढून टाका, तुम्ही लॅपटॉपचे कीबोर्ड वापरा.
लॅपटॉप त्याच्यावर करतो.
माउस काढून टाका, की लॅपटॉपचा कीबोर्ड
माऊस
वापरा.
काढा.
सर मी आता चॅट बॉक्स मध्ये माझा आयडी दिलाय. इफ यू सेंड अ प्रेझेंटेशन
याच्याने कर.
मॅडम रिमोटनी करा ना ऑपरेट तुम्ही.
केलं सर मी एकदा, पण
त्यांना माउस काढायला सांगा आणि रिमोटनी
पहिला
कंट्रोल
slide
करून
लावा.
रिमोटनी
पहिला slide
टेक ओव्हर करा.
सर मी केलं
आलंय.
ट्राय, हेच होतोय, स्क्रोल होतोय सारखा. मी
नाही, मग त्यांचा माउस कनेक्ट ना, माउस काढायला सांगा त्यांना.
येस
माउस काढा सर तुम्ही आणि कंट्रोल
काढला.
मॅडम द्या.
येस येस आय हॅव रिमूव्ड द माऊस.
हा कंट्रोल मॅडम घ्या.
आता आलंय.
बघा आता.
नेक्स्ट स्लाइड.
नेक्स्ट
करा.
एरो की वापरा सर, एरो की.
मॅक्झिमाइज करा.
आता स्लाइड शो करून बघा ना आता.
मॅडम तुमच्याकडे कंट्रोल आलाय का आता?
हो सर मी रिक्वेस्ट
वैद्य सर तुम्ही आता टच करू नका लॅपटॉपला.
येस येस
येस आता येतंय.
Perfect, sir. Perfect. Please go ahead.
ना चालू ठेवा. कुठली स्लाइड पाहिजे?
नेक्स्ट स्लाइड. नेक्स्ट.
So we are coming to, we had the regular investigations.
Yes, sir. Sir,
Would you like to have some more investigations?
yes, sir. Sir, at this stage, we would like to have bone marrow picture of this child, as well as HB electrophoresis. But since the RBC count is on the lower side, hemolytic conditions like thalassemia, they look less likely since the RBC count is also on the lower side. So that is less likely, but bone marrow would definitely be warranted in this child.
Right. Usually the thalassemia, the organomegaly starts around 6 months.
Yes.
So, right. Some of you might have guessed the diagnosis also by doing this thing, but it is not important. Diagnosis is not at all important. It is how we approach to the case of, for solving that is more important. So there were studies were done. The iron was 435 milligram percent and the iron binding capacity 310. What do you confer from this?
There is no iron deficiency. It is iron sufficiency level.
So iron is increased actually.
Yeah.
Then we did torch, say one of the common causes of organomegaly can be a torch. As you said, hemolytic anemia, we did electrophoresis, but sometimes some combination variants may present. I have seen cases of congenital tuberculosis also, presenting with organomegaly, hepato and splenomegaly. But the children are quite sick. So that was a gastric aspirate also we did that turned out negative. So any different thoughts, any rare condition you can think of?
Sir, given the investigations at this point of time, we need to rule out malignancies. We can think in terms of some storage disorders.
Right.
Yes.
Any more conditions at the age of 2 months?
Myelofibrosis.
Torch we have ruled out.
Torch is ruled out.
Electrophoresis we have done. So there is no hemolytic anemia. Any more investigations you would like to do?
Sir, bone marrow?
Right. Okay. There was also one more condition we should consider is osteopetrosis, where they can present as extramedullary hematopoiesis. So they can present with hepatosplenomegaly, low platelet count. So the infantogram was done, that was normal. Fundus was negative for cherry red spots that we usually see for the storage disorders like Niemann-Pick disease. Yeah. Gaucher disease, we could have seen some, we can see some evidence in the bone marrow, yes, as you told. So bone marrow studies were done. The erythroid series, normoblastic hyperplasia, then myeloid series, mild dysplasia. Then lymphoid series was hyperplastic. Megakaryocytic was dysmegakaryocytosis. Some histiocytes and hemophagocytes were seen.
Correct. So what was the ferritin and triglyceride levels?
Right, we'll come to that. So these were the hemophagocytes we could see in the bone marrow.
So it looks like
What is the differential diagnosis we are coming up with?
Looks like macrophage activation syndrome, sir.
Right.
That is HLH. Yes. And looks like a secondary.
So differential diagnosis as we that's entertained osteopetrosis, myelosclerosis, myelodysplasias, sepsis, congenital infection, perinatal infections, and storage disorders. Malignancies, as you rightly pointed out, leukemia, lymphomas. Then autoimmune lymphoproliferative syndromes, usually they present with lymphadenopathy. So that is ruled out. And the last, as you told, is remaining is macrophage activation syndrome. So for diagnosis, coming to the diagnosis, as we thought initially due to osteopetrosis, torch, malignancy, as you rightly told, it came to our minds also that it might be malignancy, not be a storage disorder. And we worked according to, we have ruled out that thing. After excluding these possibilities, considering the bicytopenia, there is, as you saw in the blood counts, the hemoglobin was reduced and the platelets were there. Was bicytopenia, target cell, layered of cells. So dysplastic bone marrow was there. The presence of histiocytes and hemophagocytes in the bone marrow. The diagnosis of macrophage activity syndrome or familial HLH was considered. Now, any investigations to confirm?
Sir, serum ferritin levels, triglycerides.
Right. Any more?
ESR, what was the ESR?
Right. Any more investigations to confirm?
Fibrinogen levels.
Right. So, iron, as we are looked at iron series 435, it is an elevated iron. Triglycerides is one of the key investigation. They were also raised. The serum ferritin was 16,600. And genetic studies are required to confirm the HLH diagnosis. Now, why have come to the diagnosis of HLH? What is the reasoning? It is based on the HLH 2004 guidelines. According to the guidelines set by HLH 2004, she fulfilled 5 criteria of those: fever, hepatosplenomegaly, hypertriglyceridemia, ferritin greater than 10,000 micrograms, HB less than 10 grams per cent, platelet count less than 1 lakh, and the reduced NK cell activity that we will later see. The patient was started on daily high dose of dexamethasone and IV IG immunoglobulin was given. Though etoposide was advised by our rheumatologist, we have no experience in giving, so we avoided that. Significant improvement was noticed, fever subsided, RBC platelets, hemoglobin levels increased to a considerable extent, and patient continued to recover. And this patient was referred to higher center for genetic assays, and that was the genetic assay, reduced perforin levels and reduced granular release assay for our NK cell activity was reduced. That was the genetic assay confirming the diagnosis of HLH. Now, just to few lines about HLH. It is can be hereditary or acquired. Familial, aggressive, and life-threatening syndrome of excessive immune activation is seen in infants, birth to 18 months. And acquired is after in older children, it is usually acquired and is classified under one of the rare diseases by International Registry. These are the guidelines set by the HLH 2004. Fever, splenomegaly, cytopenias, hypertriglyceridemias, or hypofibrinogenemia. Triglycerides more than 265, hemophagocytes in the bone marrow, low or absent NK cell activity, ferritin more than 500, and soluble CD25, interleukin-2 receptor more than 2400 international. These are the international HLH guidelines set. At any 5, actually they are established one either or 2 is fulfilled. For our case was fitting 5 of the criteria. The treatment was dexamethasone, fludarabine, immunoglobulin, etoposide, cyclosporin, and bone marrow stem cells transplant is the definitive treatment. Now, how to treat differs. All hematologists have a different say, and the rheumatologists have different say. Hematologists, they treat by familial HLH treatment protocols, which include etoposide and dexamethasone, while hematologists, they prefer pulse dose corticosteroids and anakinra or tocilizumab. Intense phase will usually often be faced with secondary HLH, common in dengue and other infections, hyperproteinemic sepsis-induced multi-organ dysfunction syndrome, and generally adequate source control with antimicrobial therapy and supportive care, along with adjunctive therapies such as methylprednisolone, IVIG, and plasma exchange. Now, I will not go in the details of algorithm. Thank you, Maha IP team, and thank you the participating team for coming to the diagnosis.
Yes.
I thank Maha IP team for giving me this opportunity.
Thank you, sir.
Thank you, sir. Thank you.
Shall I stop sharing the screen?
Dr. Basalraj, would you please come in?
Yeah. This is first of all excellent case by Professor Sunil Vaidya sir, and equally cracked by the Parikshit sir team and all. First, let me go through this case. Just 2-month-old child comes with a fever, with excessive irritability, then refusal of feed. As a clinician in the emergency department, most of the time, we will be bothering about the diagnosis. So diagnosis is not an important thing. Taking care of airway, breathing, circulation, that is stabilization is the key. The moment you stabilize, next thing comes is, what will be our possible thought when the things like this? First thing which comes to the mind is a pyogenic meningitis with complication. That's the first thing which comes to the mind. Fever, irritability, altered sensorium, 2-month-old child. It cannot be simple case of a pyogenic meningitis. It can be a pyogenic meningitis with complication. That's the thing which comes to the mind. Looking at onset, duration, and progression of a disease. The moment you examine, in this case, there was an anemia. Second thing is there was a bruise, but anterior frontally at level. If the anterior frontally is the thing, that is the time where we'll think about, could it be intracranial bleed? But intracranial bleed going for 15 days is a little unusual. We don't think about that also. The moment you examine the abdominal examination, you got a hepatomegaly, splenomegaly. The one of the thing what is most important is we need to look at the consistency of the liver and spleen. That's very, very important. If there is a firm hepatosplenomegaly, that indicates this is the process which started from the birth. It cannot be in just, it is from the antenatal thing. That way, the consistency is going to play an important role on that. But in coming back to this case, presence of an hepatosplenomegaly with fever, with irritability, with reticuloendothelial cell involvement and all, Since sir has said this is the case which has been before the COVID. If it were to be in the during the COVID, my thought would have been multi-system inflammatory syndrome, especially Delta is the thing which comes to the mind as an intensivist. I'll think about Missy as one of the things. But the team is rightly thought, yes, malignancy could be one of the things. Congenital leukemia definitely is in a right thought before the COVID things. I'll totally agree with that. The one of the things, especially because there are 3 cell lines is affected. One is a coagulation cascade system is affected with the terms of a brucine and all. And the anemia was there, reticular endothelial cell involvement was there, CNS involvement, multi-system and all. Yes, congenital leukemia could be one of the possible things. I'll not say no, but it will be my down the list. But before that, some storage disorder is another thing you rightly thought it is storage disorder. I'll not be too enthusiastic to go into the torch infection. Why? This child was born no failure to thrive. That's why I'll be not in a will be enthusiastic to think about torches and one of the possible things. So that's how my before the coming to the examination, this will be my thoughts when it comes to the things like this. The moment I reach an investigation, CBC is the one thing which is really has thrown a lot of things. Presence of anemia, thrombocytopenia, neutropenia. That's the time with the hepatomegaly, splenomegaly, apart from malignancy, this is the time I'll think, okay, this is not something which is nothing to do with a pyogenic meningitis, nothing to do with our intracranial bleed. So it must be something which has been started from the birth. Either I'll think about in a primary HLH at this stage itself, the moment I start looking at the thing with investigation, or leukemia, even though I think, but 26%. It is not in exactly when you look at the net 5,000 plus up in accounts and all. I'll not be enthusiastic to go into the leukemia. I'll move away from the leukemia towards a primary HLH is the thing, because most of the time in the intensive care we do see that. That's why as a clinician we'll move at this stage. And before going to the bone marrow, what I'll look into that, okay, bone marrow is the thing which is really required. Straight away, I'll go into the ferritin at this stage itself. Ferritin and triglyceride is the thing I'll look at this stage. Then I'll plan for a bone marrow. So that will be my approach in this type of case. It's an absolutely a fantastic case, and thanks to both the teams.
Thank you. Thank you, sir.
Yeah.
Thank you so much, Sunil Vaidya sir, and excellent cracking the case team today. So it was a good approach for the diagnosis with proper differential diagnosis given. So let us go to the next case for today. I'll request Dr. Shiv Prasad sir to please share his screen and Team Jalgaon to take the case.
Other participants should stop sharing.
Yes, sir, nobody is sharing anything. So you can share your screen.
Good evening to respected teachers and best wishes for the Jalgaon team. I will start the case with permission of Basavaraj sir, Mohite sir, Shilpa ma'am, Sunita ma'am. Before starting this case, just highlighting the background of the case. This case is from rural area and presented to us in a government medical college, which have limited but necessary investigative backup. This case presented to us from a private practitioner pediatrician. Our teacher, Dr. Mohite sir, used to say, second reference are always different and challenging. Don't take it lightly. During the COVID pandemic second wave, 1 month, 4-day-old child presented with history of distension of abdomen, breathlessness, fever, irritability, not feeding well, and periumbilical redness and skin ulceration over the inguinal region. This is the ulceration. Rest. Clinical examination finding, child was hemodynamically stable, no pallor, no shock, abdomen was distended, no hepatosplenomegaly, no jaundice, conscious, active, feeding. Though breathlessness was there, the child was feeding well. History from available record which the parent presented to us. A third child, elder two sister, born by normal delivery at another government college, Ambezogai, admitted to NICU at Ambezogai on 7th day for umbilical sepsis as mentioned and in discharge card. Clinical diagnosis and what next? Any questions from the team?
Sir, any vomiting, abdomen related complaint like bilious vomiting?
No other symptoms were there except distension and decreased feeding. There was no vomiting.
How was the onset? Like whether it was a very acute presentation or the distension along with this lower inguinal region ulceration went on very slowly or very acute presentation?
The presentation was from last 4 to 5 days, though the child is giving admission history for first 15 days of life, first 8 to 15 days of life. And child presented at 1 month of life. Means probably, though the parents are telling that the child is ill since 4 days, our thought goes that child might be ill since the discharge also, since last discharge.
Okay. Was there any history of any injury at the inguinal region? Sometimes in the rural area for distension and complaint, they do some stuff like giving some burn injury and all these things.
No such history is there. This ulcerations was incidental finding on one fine morning.
How was the child in between the two illnesses, sir? Like from discharge in the government hospital and in between when the child was at home, whether he was feeding well or not taking feeds well?
Child feeding was good in between the admission from first and this admission, but child was having breathlessness and intermittent distension of abdomen.
Okay.
So presently your diagnosis like us might be sepsis.
Sepsis.
Right. So we proceeded with sepsis and investigated baseline investigations. Hemoglobin was 8.4. Total leukocyte count was 1,21,000. Neutrophil, lymphocyte, and eosinophils were normal. Platelet counts were 3,46,000. And no other abnormality on the CBC was seen. On PS, there were no blast cells. Only leukocyte reaction was the comment from the pathologist. CRP was 100 and other cultures shown no growth eventually after 3-4 days.
Counts what? Sir, in this thing you mentioned, this is total WBC count 1,21,000, no sir?
Right, sir.
And neutrophil 68, lymphocyte just 9. So what else? The remaining 100%. So lymphocyte is a low, very low ALC count. Like what was the basophil or something like that?
Eosinophil was 1, monocyte was 3.
So ALC is low. So lymphocyte 9% is right, no?
Right. Lymphocyte was 0.9.
So there is a severe lymphopenia is there with lymphocytosis.
Okay.
And platelets, sir?
Platelet was 3,46,000.
Okay. Anemia.
Others to complete the 100%, they have different cells. Myelocytes 0.3, metamyelocytes 0.5, band cells 0.7, myeloblast 0.2, promyelocytes 0.2, nucleated RBCs were seen on PS.
So this report is showing anemia, lymphopenia, leukocytosis, high CRP, so suggestive of very bad sepsis, though cultures not showing any growth.
Right. So we continue with the same diagnosis of sepsis with ulceration, started on antibiotic, NICU care, oxygen if required according to the SpO2, NBM for a meanwhile because distension was there. Same treatment you would like to give or you have to add something?
We'll get X-ray.
Sir,
X-ray. We will have to chest X-ray and abdomen X-ray and ultrasonography of abdomen.
Okay. Chest X-ray, ultrasonography of abdomen was normal. Ultrasonography was showing gaseous distension. No HS megaly on USG was also there. X-ray chest was also normal. No infection signs were there.
Electrolytes, sir?
Electrolytes are normal.
Renal function.
Renal functions were done. They were normal.
ABG, sir? Is there any way like acidosis? We just want to know.
Actually, clinically, there were no signs such as suggestive of acidosis. We have not done ABG.
Breathlessness was one of the complaint.
So yeah, breathlessness was there, which was settled on flow of oxygen, minimal flow of oxygen. So what we have started with NICU care, NBM, oxygen, and antibiotics and IV fluids. The child for next 5 days clinically improved. Now the oxygen was not stopped. The child was taken on breastfeeding. The child was in NICU. Ulcer was same or slightly progressed. Count were same or increasing, more than 1 lakh only. Now at this stage, what should be your thought process?
Primary immunodeficiency, sir, like SCID. There is a severe lymphopenia is there in the primary one counts, whatever you had shown with coming with sepsis, bad sepsis, because though there is a localized ulcerative lesion, the child has got some tachypnea, abdominal distension, so some systemic symptoms. So this is a localized ulceration with some systemic sepsis like presentation, which initially responded to some primary antibiotics, whatever you have covered. But at the same time, considering the rest of the picture from the peripheral smear and whatever we got, it looks like maybe primary immunodeficiency.
Okay, what about malignancy?
Child is otherwise in between was thriving well.
Not sick looking child, responded quickly, no organomegaly, you said. Yeah, plus CRP is also 100. And platelet counts are normal, though there is some mild anemia. Means with this so much leukocytosis, suppose they're in bone marrow, there has to be some platelet suppression. So this can be leukemoid reaction. Bone marrow might be normal, but periphery is high leukocytosis is there.
So you don't want to go for a bone marrow in this child?
Yes, we can. We need to do, sir. We have to do. If the child is now, you said there is some improvement. So at this point of time, we will repeat the WBC count. We'll see how the response is there. So
this is the day 8 of admission. The child was improving clinically, but counts were same. So we planned for a bone marrow biopsy and a lab score, leukocyte alkaline phosphatase score, which is the blood marker for CML. This was the PS picture, peripheral smear. And this was the bone marrow. Bone marrow, as we thought, it was just a chronic myeloproliferative disease, nothing such as leukemia or CML. The child continued with the same count On day 11 to day 15, child given some other symptoms. This was a COVID era of a second wave. The palate is broken.
This looks like sir, high WBC count blocking the small vessels, small arteries, and causing all these necrosis and dry gangrene like pictures. The ulcer can be now fitting into the pictures. WBC high count is blocking the vessels and causing all these demarcated ulcers and gangrene like picture.
Microangiopathy.
Okay. Okay. The story ends here. Now you need further any investigations to plan or diagnosis anything?
Flow cytometry.
Flow cytometry, sir. CD markers.
Yes. This child clinically, the first at the time of the first admission, this was its discharge card. This shows persistent high count, 37,000, 35,000, 55,000. These were the TLC at the time of admission at the first 7 days of life. Though they label it has been umbilical sepsis, but what we observed during the ward course, there was no pus in the ulcer. And you have rightly clicked the diagnosis by diagnosing it as a leukocyte adenase deficiency, LAD type 1. But there was no pus in the ulcer, and we were misled by the previous diagnosis as umbilical sepsis. Actually, it was just a redness at that time also. Probably there was no pus at that time also. We done the flow cytometry of this child, and we had absent type 1 of LAD, 0 neutrophils showing, 0% of neutrophils are positive for CD18 and CD11A. So our diagnosis was of LAD type 1. And the child after 2 months or after 2 months or 3 months succumbed, and we are not able to do bone marrow transplant of this child. But fortunately, we were able to give the diagnosis to the child, and we planned other pregnancies of the child so that they can have a healthy baby. Thank you. Thank you for discussion.
Thank you. Thank you.
Excellent case.
That was an excellent case, sir. And congratulations, Team Jalgaon. Dr. Basalraja, sir, kindly give your comments.
Sir, can you stop sharing it, Shivaprasad, sir?
Yes.
Yeah. This is a really a wonderful case. So this is the type of a case we do get once in a while. Of course, when the sir presented the case, initially thoughts will be yes, severe sepsis. We know that newborn is always behaves unusually. There will be in the moment any total leukocyte count of anything more than 40 to 50,000. We think generally about some leukemia reaction exaggerated to the severe sepsis. That's why child is behaving, because CRP is also almost 100. But what is important, one of the clue here was two things. There was no thrombocytopenia. If it were to be severe sepsis, thrombocytopenia will be the thing. In the acute, in the initial stage, yes, there will be thrombocytosis, later thrombocytopenia. That's accepted. But severe sepsis, thrombocytopenia would be one of the things. Lymphopenia is another thing. The moment lymphopenia is there, we always bound to think about SCID is one of the possible things. That's absolutely right thing to think about SCID as one of the possible things. But the subtle clue like an umbilical sepsis, that's the history. Always 90 to 95% of the diagnosis in the pediatric clinical practice depends upon the history, onset, duration, and progression. This is what is a very important. That was the clue which was important to think about in a possibility of leukocyte adhesion deficiency. Before that, myeloproliferative disorder is another thing. Yes, we need to think about myeloproliferative disorder. And one more important thing is always look at the phenotypic presentation of a Down syndrome. Downs is one of the things. Always the moment there is a leukocyte reaction, you need to think about a Downs. Of course, in this, there was no features which is suggestive of a Down syndrome. Otherwise, my thought would have been, oh, let me look into is there any evidence of a phenotypic presentation of a Downs? That's where sometimes we can get any confusion in the thing. So this will be the thing. Otherwise, by and large, I'll go with what the team is really went with an approach of an scale, then thinking about a malignancy. Of course, primary HLH, MIS-C, and all those things can be the few thoughts which comes in the thing. But ultimately, leukocyte adhesion deficiency is the thing, the subtle clue, like without a pus, if there is an umbilical cord which is not falling down, that will give a thing for thinking about lag is a thing. Flow cytometry is one of the investigation that is rightly thought. BMT, if you have identified early, bone marrow transplantation, it would have been a thing. But in a government hospital, what Shuprasad sir said, this is what we prolong. Ultimately, by the time severe sepsis and infection will take away the things. Over to you, Dr.
Moite sir, your comments.
lot of learning points. I'll start from the case 2 itself. Wonderful case, Shiv. As usual, he is a brilliant person. When he was working with me, I had picked up some extraordinary. I still remember Shiv picking up a biotinidase deficiency and Shiv picking up a rubella. Am I right? Not rubella. I'm sorry.
CMV pneumonia.
CMV, right? So he is always brilliant. So this particular case, I think clues are ulceration without pus. I think especially in the infantile age group, ulcer without pus. Secondly, this child had come out of NICU for 15 days, recovered from whatever so-called recovered, but within no time, another 1 week, again comes with a tachypnea without any primary respiratory features, neither on the X-ray nor clinically. So that tachypnea was attributable to probably again infection, and important, quickly recovers also with antibiotic. So this is another clue, infection which responds but recurs again and again. So that is unusual here. He is responding to routine antibiotics but recurs again. And third, of course, what Rahul made a mention, localized ulceration giving rise to systemic symptoms. Why it should be. Now in the neonate and in peri-neonate, you can get that, but happening again and again, it's a clue to immunodeficiency. So all in all, that last picture which you showed was a classical pseudonoma. That's what we call it. It's not actually a blockage of the vessels by your neutrophils. Actually, it's a pseudonoma. Typically, we used to show that pseudomonas infection coming and literally breaking your palate and everything. And one more thing I wanted to make, actually, the absolute lymphocyte count which you mentioned, here it was 9% of 1.2 lakh, that comes to 10,000. So anything above 3,000 is normal. So actually, this was clearly leukocytosis, not a lymphopenia. And making all together, we are all kind of tuned for a prolonged fall of the cord as LAD, prolonged cord of the fall is LAD. Let's come out of that. Ulcer which is not recovering, ulcer which is without pus, infection which recovers quickly with the antibiotic but recurs again and again. Think of LAD and then then get the rest of the picture. Coming to the first case, another few interesting clues. Somebody said, when I get a prolonged fever of 15 days, I mean, that was a combination. When I written few points, very interesting because I found it really interesting. This was a case of prolonged fever with hepatosplenomegaly and pancytopenia. Now, fever, which was definitely significant, documented for significant time. So, wherein the non-inflammatory, non-infective pathologies, I'll keep lower on card. So, your storage, hemolytic anemia, osteopetrosis, myelodysplasia will be lower on card. And I'll take infection, inflammation on a higher part. So, inflammation, which is infective or non-infective. So, on infective side, you discussed about congenital infection, toxoplasma. They won't come standalone. If it is antenatally had, then you would have multi other presentations, skin rashes, failure to thrive. I mean, this IUGR baby quite often, and then progress will, and would be really peaking at birth and then subsequently taking its own course. One which is acquired postnatally won't have such a huge hepatosplenomegaly. I'll keep lower down on card. So it's probably a non-inflammatory, which you went excellently that it was malignancy and coming it. One clue towards HLH is the discrepancy between ESR and CRP, where because fibrinogen is low, you will have low ESR and CRP. So nowadays, whenever we send CBC, CRP, we always send this kind of a PO patient, ESR, CRP together. So in a condition where you have ESR high and low CRP, you're looking at probably SLE, and vice versa. If it is low ESR, high CRP, you're looking at HLH as a combination. Somebody said about a dengue HLH. Now, this is something which is in really good kind of a discussion nowadays. Dengue without HLH can have very high ferritin, maybe up to 50,000. We have seen very commonly. So the reason, perhaps one of the reason is it's a genetic upregulation. The same gene which causes increased HLH or increased ferritin is upregulated by dengue virus itself. So that doesn't mean high HLH, high ferritin doesn't mean HLH. So nowadays what we consider, unless there is an organ dysfunction associated with high ferritin, then we call it as HLH in this combination. So that was my comment. Amazing cases. 12 cases we have presented, or maybe this was 14 cases. I have got most of them in my storage. It's a luxury to have those cases. And both the teams did extremely well. They were right on track. I think that's sole purpose of it, to have an approach to these cases. And Basavaraj will agree, the people who speak on the dais, perhaps the people standing lower down are far more intelligent and talented than the people who sit on the dais. I think you are going to be president. So take care of these people who are sitting in the crowd, there are excellent talents everywhere. You will have to, we should have a talent hunt now for this. So one of my thinking, I mean, this year I'm not attending the state conference. I already told Ramakan, there should be a session called as Kaun Banega Faculty. A session where you invite people from the crowd to sit on the dais and take the challenges directly. Kaun Banega Faculty. I think Ramakan, you must be remembering that. So take that. Unfortunately, I won't be able to attend this time state conference for some other personal commitments. But thank you very much. Absolutely wonderful cases and absolutely wonderfully cracked by both the teams. Thank you very much.
Dr. Mahesh, one comment. This is not the cut and paste or something which is a theoretically. It is the real experience.
Absolutely.
That's why it is very, very important in the clinical practice. Yes. Absolutely, I totally agree with your comments. This is the way we need to learn.
Dr. Ramakan Patil, sir. Yes.
Basavaraj sir, whatever Dr. Mahesh sir says, whether it is unintentionally, intentionally, inadvertently, he said you are going to be president. So that is a final word. So the moment I filed form for EB membership, he said you are going to be EB member, go for trek. And I listened to him and I went for trek. so it is already. Now you are going to be president. Secondly, in this case, as already.
You are not audible.
I'm not audible?
Yeah, now it's here. It's okay. Just come.
Yeah, it is a wonderful case. What you have already told that it is any umbilical sepsis, we need to have for diagnosis, there is some purulent discharge. So this purulent discharge was not there. That is very important. And this is a NOMA. I have seen only one case. You said pseudonoma, but this is nocardiasis, NOMA. Because had it been pseudomonas, child would have been very, very toxic. So nocardiasis, like this thing, that can cause severe infection without inflammation, even rupture of palate. Very classical NOMA because of nocardiasis. It is because of leukocyte adhesion defect. Wonderful case, and we'll need immunoglobulin, monoclonal antibody. Probably patient will not afford it, but the bone marrow transplant is the treatment for that. Till that time, monoclonal antibody is to be given. Thank you, Mohit sir, for giving a wonderful. Thank you. And I appeal all to come for, even if Mohit sir is not able to come, other members to come to Nashik. And Basavaraj sir also, I invite him.
Thank you.
Oh, thank you. We also overcame our challenge thanks to Dr. Pallavi Madam. She helped us through the initial first case. And thank you so much, Basalraj sir, Sunil Vaidya sir and Shiv Prasad sir, and both the teams from Jalgaon and Dhule. Thank you so much. And for the vote of thanks, I'll hand over to Dr. Neha ma'am.
Thank you, Shilpa. Yes, for the vote of thanks. On behalf of Maha AP, first of all, I would like to thank our today's expert, dear Dr. Basavaraj sir. Thank you so much, sir, for finding out time. Busy schedule and accepting our invitation for being today's case challenge expert. Thank you so much, sir, for your wonderful expert comments at the end of each cases. I would like to thank the case presenters of today, Dr. Sunil Vaidya sir and Dr. Shiv sir, for presenting such interesting cases today. Both the teams, Jalgaon team and Dhule team, have done very well. Good clinical approach, both of you. Congratulations and thank you for your active participation. Our special thanks to Dr. Mohite sir, who came with this wonderful idea of case challenge. And sir is always there for us in any academic help. Thank you so much, sir, for all your support. I would like to thank our Maha AP President, Dr. Hemant Gangulia sir, and Secretary General, Dr. Amol Pawar sir, Scientific Convener, Dr. Jay Pandarkar sir, and other EB and OB members of Maha AP for joining us today. Dr. Sunita Ingle ma'am and Dr. Shilpa, thank you so much for moderating today's case challenge. Also, thank you, Pallavi ma'am and Vishal Raj sir, for all the technical support. I would like to thank all the attendees on Zoom and YouTube Live for joining us today. Our next case challenge will be on 3rd Friday of September, that is 16th September, while next Friday of August will be our Mahakatta program. Requesting everyone to please join. Thank you so much. Good night.
Thank you very much.
Thank you, Maha AP. Thank you. It's a wonderful learning for us.